Hello again, everyone. Let's now continue with the second part of the different disorders of lipid and lipoprotein metabolism. In part 1, we were able to discuss the different reference ranges for the lipid profile, and we were able to talk about two of the conditions related to the lipid and lipoprotein abnormalities, and that is atherosclerosis and coronary heart disease. For part 2, we will now discuss dyslipidemias. Dyslipidemias are diseases associated with abnormal lipid concentrations. And when we say abnormal, these are the unhealthy levels or unhealthy concentrations of the different lipids or fats in the blood. Dyslipidemia may be a direct disease or a secondary disease. Direct dyslipidemias are mainly caused by genetic abnormalities or may even be from the environmental or lifestyle imbalance of the individual. Secondary dyslipidemias may be caused by other diseases like diabetes and obesity. Dyslipidemias are involved in both the forward transport and the reverse transport of lipids. The following discussion will talk about the different disorders associated with the forward transport of lipids. Examples would be chylomicron retention and hypobetalipoproteinemia. The first dyslipidemia is the chylomicron retention disease, also known as the Anderson's disease. In this condition, ApoB-48 is mainly affected, which is the main lipoprotein found in chylomicrons, hence the name chylomicron retention disease. This condition is also mainly found in childhood or in children, which presents fat malabsorption. With fat malabsorption, that means that there is a decrease in total cholesterol and triglyceride in the blood. With this condition, signs and symptoms include hypoalphalipoprotein because of the decreased triglyceride and total cholesterol in the blood, chronic diarrhea. Failure to thrive is seen in children who have a low weight compared to others. And because of this, there is also a deficiency in fat-soluble vitamins like vitamin E, since there is a decrease in the lipids which are needed for the absorption of fat-soluble vitamins. The second dyslipidemia is known as the familial hypobetalipoproteinemia, abbreviated as FHBL. Familial because it is inherited as an autosomal dominant disorder of the ApoB gene. The mutation of this gene, and when we say point mutation, it's either a nonsense or a missense, and we will learn more about these when we get to molecular biology. The significance of the mutation in this gene is that it impairs the ability of the body to absorb and to transport fat. Familial hypobetalipoproteinemia generally has a decreased lipid value in the blood, and because of this, it is associated with a decreased risk for having or for developing chronic heart disease. FHBL may be categorized into two, homozygous and heterozygous. Homozygous FHBL is present in an early age, which also presents with fat malabsorption because of the decreased cholesterol and triglyceride level. Total cholesterol levels are usually less than 50 milligrams per deciliter. Heterozygous also has a decreased lipid value, decreased LDL, total cholesterol, and triglyceride, with only HDL having a normal or a slightly increased value. Heterozygous FHBL is usually asymptomatic. But if symptoms do happen, neurologic degenerative disease, retinitis pigmentosa, and acanthocytosis may be seen, which are also present in another condition, which is abetalipoproteinemia. The non-familial forms of HBL are only secondary to other conditions like cancers, liver disease, and severe malnutrition. The third dyslipidemia is abetalipoproteinemia, otherwise known as the Bassin-Cornswig syndrome. This is a rare autosomal recessive disorder which affects the MTTP gene. This gene is responsible for the MTP protein, or the microsomal triglyceride transfer protein. This is also a defective Apo B synthesis condition. The MTTP gene is located in chromosome 4 with an approximate number of 894 amino acids. Because of the defective Apo B synthesis, there is a decrease in total cholesterol and triglyceride level and undetectable VLDL, LDL, and chylomicron levels. Because of the undetectable levels of these three lipids, this is known as the abeta, or the absent lipoprotein condition. The same with HBL, or hypobetalipoproteinemia. It also presents in early adolescence or childhood with fat malabsorption and hypolipidemia because of the decreased total cholesterol and triglyceride levels. Other signs and symptoms would be retinitis pigmentosa, cerebellar ataxia, and acanthocytosis, also found in HBL. Because of fat malabsorption, fat-soluble vitamins are also affected, like vitamin A, K, and E, leading to its deficiencies. The next dyslipidemia is the LPL deficiency, which is also a rare autosomal recessive disorder affecting the LPL. Either a defect in LPL is seen or an absence in its concentration. LPL stands for lipoprotein lipase. LPL is the one responsible for the hydrolysis of triglycerides. So without LPL, there will be an increase in triglyceride level. Since total cholesterol is not involved, it will have a normal concentration. The fifth dyslipidemia is the ApoC-II deficiency, which is mostly the same with an LPL deficiency. Why? Because ApoC-II is the activating cofactor for LPL. So with the absence or the deficiency of ApoC-II, there would also be a deficiency in LPL. That's why these two are generally the same. Laboratory results are also the same, with normal total cholesterol and an increased triglyceride level. The next dyslipidemia would be the familial hypercholesterolemia, or FH for short. This is an autosomal dominant disorder affecting the LDL receptor gene. Now, a defect in the receptor for LDL means that these receptors cannot bind or cannot clear the LDL from the circulation, therefore having an increased total cholesterol and LDL levels. The mutated gene is seen in chromosome 19. There are two types of FH. We have homozygous and heterozygous. Homozygous is the rare type with only 1:1 million in the population. They have high total cholesterol levels of usually 800 to 1000 milligrams per deciliter. And they can have their first heart attack during their teenage years. The second type is the heterozygous FH, which is more frequent than the homozygous, with a 1:500 in the population. The cholesterol level is usually 300 to 600 milligrams per deciliter. Now, if this is not treated, it becomes symptomatic for heart disease in their 20s or in their up to their 50s. The following symptoms may be seen in FH. The first one is xanthomas, which is defined as having cholesterol deposits under the skin. The second one is what we call the arcus, where the cholesterol deposit is seen in the cornea of the eye. The next dyslipidemia is the familial defective Apo B, which is an autosomal dominant disorder. This has something to do with the LDL receptor again, but this time, since the mutation is in the Apo B gene, the defect is in the Apo B-100, which interferes with the recognition of the receptor cell. Laboratory results would be increased total cholesterol and LDL. These pictures would show the difference between familial hypercholesterolemia and a defective Apo B. In the FH, there is a defect in the receptor itself, which does not permit the binding of the Apo B lipoprotein, while in the defective Apo B condition, the receptors are okay. There is nothing wrong with the receptors, but there is a defect in the Apo B itself that does not permit its binding to the receptor, and both of these conditions lead to the accumulation of LDL in the circulation because of the non-binding of the Apo B to the receptors. Our next dyslipidemia is Dysbetalipoprotein, which is caused by the presence of a rare lipoprotein, which is ApoE. This lipoprotein has a lower affinity to the LDL receptors, leading to its accumulation in the circulation. Therefore, a high total cholesterol and a high triglyceride level. This type of disorder affects adults more and men more than women. Dysbetalipoproteinemia may be diagnosed through electrophoresis, and in this picture, the one on top is a normal electrophoretic pattern showing the HDL, the VLDL, and the LDL. But in cases of dysbetalipoproteinemia, there is a very thick band seen in between the LDL and the VLDL. This is the electrophoretic pattern for the dysbetalipoproteinemia, which is also known, the band, also known as the abnormally migrating beta lipoprotein or the floating beta lipoprotein. This is a chart showing the summary of the different dyslipidemias involving the forward transport. For the first three conditions, there would be a decreased total cholesterol and triglyceride level affecting mostly the Apo B lipoprotein, while LPL deficiency and ApoC deficiency will have a normal total cholesterol and a high triglyceride level. Familial hypercholesterolemia and familial defective Apo B would have an increase in both total cholesterol and LDL, while in dysbetalipoproteinemia there is also a high total cholesterol and triglyceride level affecting the rare ApoE lipoprotein. Let's now go to the different disorders involved in the reverse transport of lipids. Our first condition is the Tangier disease, which is a rare autosomal recessive disorder caused by the mutation of the ABCA1 gene, which leads to the decreased or undetectable levels of HDL. HDL levels may go as low as 1 to 2 milligrams per deciliter. The mutation leads to the ineffectivity or inability to transfer cholesterol, which is inside the cell, going to the plasma. Now, without this process, HDL cannot be formed, therefore leading to the decreased value. Pathognomonic to Tangier disease is the enlarged grayish or yellow-orange tonsils. Our next condition is the LCAT deficiency, which is a very rare autosomal recessive disorder caused by the mutation of the LCAT gene. Now, without the LCAT, or because of the mutation of the LCAT, the cholesterol remains unesterified. And if cholesterol remains unesterified, this will impede in the synthesis of HDL, therefore having a low HDL level. Levels for LCAT deficiency HDL are usually less than 10 milligrams per deciliter. There are two forms of LCAT disease, and the first one is known as the classic or the complete LCAT deficiency, which is described with having anemia, proteinuria, and renal failure. The second one is the partial. Another name is the fisheye disease, as seen in the picture, where it is milder than the first form, but it has progressive corneal opacification. Our next condition is the familial hypoalphalipoproteinemia, which is a common autosomal dominant disorder. Common because it has a ratio of 1:400 people in a population. And this is frequently associated with ApoA1, either with the decrease in the production of ApoA1 or an increase in ApoA1 catabolism. This leads to a decrease in HDL. For men, HDL values are usually less than 30 milligrams per deciliter, while women will have approximately less than 40 milligrams per deciliter. The next condition is the CETP deficiency, which is an autosomal recessive disorder inhibiting the transfer of cholesterol esters from HDL going to VLDLs or chylomicrons. This is a way for the HDL to indirectly deliver cholesterol going to the liver. Now, since there is a deficiency in the CETP, cholesterol cannot transfer to VLDL and triglyceride will not be given to HDL. Because of this, the HDL becomes large and are laden with cholesterol esters. This will eventually lead to an increase in HDL levels in the blood, typically more than 100 milligrams per deciliter. And our last disorder is the hepatic lipase deficiency, which is a rare familial disorder caused by the mutation of the HL gene, hence the name hepatic lipase deficiency. This is described to have a combined hyperlipidemia with an increased cholesterol and an increased triglyceride level. Total chole results are usually between 250 to 1,500 milligrams per deciliter, while triglyceride levels are often 400 to 8,000 milligrams per deciliter. HDL, on the other hand, may be normal or increased. In HL deficiency, the HDL and the LDL are usually described to have large particles with triglycerides. This is a chart showing the different dyslipidemias involved in the reverse transport. The first three conditions, Tangier, LCAT, and familial hypoalphalipoproteinemia, all show a decrease in HDL levels, while CETP deficiency, which is the opposite, shows high levels of HDL. The HL deficiency, on the other hand, would show combined hyperlipidemia with an increased total cholesterol and an increased triglyceride level. These are all the different references used in the making of this PowerPoint. Main references would be books from Bishop and Teets. And that ends our discussion about the different disorders of lipid and lipoprotein metabolism. Thank you very much for watching.